Ever since we've had options in terms of urinary diversion, there's been an attempt to, improve the decision making, the selection to try to determine what is the best diversion in the individual patient, and really it comes down to selecting these things appropriately, and really none seems to be really better than the other. These are my disclosures. What I would like to do is briefly discuss the options of urinary diversion in the context of looking at complications that may affect the decision-making process, that may alter the selection to favor one over the other. Look at a little bit of data regarding patient satisfaction and decision regret, and finally look at some of our attempts to improve the process and improve the patient experience. Okay, so briefly we'll look at diversion options that we're all familiar with. The standard, of course, is the ileal conduit, and we're all aware of the complications in some of the standard rates and reoperation rates. There are some complications that kind of rise to the forefront in terms of things that we might want to avoid in the individual patient. And for me, one of those, is that not loud enough? Was that on? Okay. And for me, one of those, is the peristomal hernia. There are some theoretical factors involved with the development of peristomal hernia, whether that's surgical technique, the stoma, say, for example, in the very obese patient, a Turnbull, which would make the abdominal wall aperture larger, BMI, nutrition, whether they're going to heal well, chemotherapy, diabetes, COPD, or anything that would increase the intra-abdominal pressure on a regular basis, chronic steroid usage. As you notice on this and see all this contents above the musculature, in addition to the conduit, this is a patient that I operated on with plastic surgery. And unfortunately, this happens, in our practice, I think, more than is often reported in the literature. The peristomal hernia rate really can go up to even 20 or 25%, depending on individual patient factors. So unfortunately, we have a pretty well fine-tuned team in terms of specific plastic surgeons that help with abdominal wall repair. And no matter what, the recurrence rate that they will report to these patients is at least 50%. Sometimes even higher. And so with keeping that in mind, you have to really kind of look at whether, make sure the patient realizes the possibilities of that and is able to maybe control some of the factors that they can in terms of, preventing this type of complication. Catheterizable diversions. These are some of the kind of historical ones. Our institutional fallback, is the Indiana pouch. However, when you look at some of these diversions, some of which are historical, you'll note that oftentimes the primary complication relates to the continence mechanism. Probably one reason why the Coke pouch is very rarely done, because that continence mechanism failed regularly. But that is a common issue. Now, for the Indiana pouch, my primary issue, or primary thing that's modifiable from the patient standpoint, and we see that these several ones that relate in higher operation rates, but is the stone rate, is the pouch stone rate, and that can be really something that is predicted based on your patient's compliance. So this is just an example of a patient that has pouch stones, and this particular pouch is actually not a traditional Indiana pouch, as you may pick up from the configuration, because it's not as round and globular. It's actually a Studer pouch that was converted, because of a urethral recurrence, and I converted it to a catheterizable diversion. But this, in the end, it's the same. The patient has these large stones that is completely related to the fact that they were not, catheterizing and or irrigating consistently. And so that's something that, if the patient says that they think they may have problems with the schedule, then, this is not the kind of diversion for them. In addition to not irrigating, it could be that there are some foreign bodies that have found their way into the pouch and have resulted in being anitis for stone formation. And usually we will do them percutaneously, but sometimes it's easier just to open over the pouch and, just pluck out all these large stones rather than even doing it percutaneously. In terms of catheterizable stomas, patients read a lot of things now online. Everybody wants the umbilical stoma because it's more cosmetic. But sometimes these can be subject to a higher failure rate. I've seen especially in more obese patients, and the blood supply can be a little bit more maybe unpredictable at the umbilicus rather than passing through the abdominal wall to the right of the umbilicus. So I usually don't suggest it. I mean, if they ask, or if it's a patient that is, very young, slender, and maybe, this would be something that would be really a game changer or make a huge difference in them, then I will do it, but I won't, do it just, for no reason. So again, but that is, another part of the decision-making process, and also there's a perception from the patient that the more hidden it is, then that may help them adjust, to what's going to be a major change for them. Orthotopic urinary diversions, again, another plethora of diversions, and we have, though, the tendency really to fall back on the Studer neobladder. And then if we look at this comparison between the Studer and Hauptmann diversions, again, the early and late complications. In the urinary leakage area here, what you may pick up, what is not included is in my perception, is the nocturnal enuresis rate, which can be really up to 30 to 40% in some series, and even in the patient who's completely dry during the day, they'll often have a loss of pelvic floor tone at night. And then resulting in what can be very severe incontinence in someone who is completely dry during the day. And this is another thing that has to be, of course, brought up to the patient, and we'll discuss how I evaluate and manage incontinence in these patients, because it can be a major problem in terms of their quality of life. But they need to know that there are options in the event that that does happen to them. So really, when we're selecting or helping them select a diversion, you're really going between the standard, rather the ileal conduit, versus our continent diversion options. And whether it's going to be orthotopic or catheterizable, we're, of course, focused on things that would be, contraindications. Their renal function, liver function, inflammatory bowel disease, which may limit how much bowel you would want to use. Age is sometimes relative, and that keeps going up as our patient's performance status with age continues to improve, and the overall compliance with managing a continent diversion. If it's specifically catheterizable, of course, we're worried about manual dexterity, coordination. Now, hypermotility syndromes. This is something that I unfortunately have experienced over time. If you do enough of these, you're going to find the patient that has an overactive Indiana pouch. And that usually it doesn't just happen. What I've seen is that if you then question the patient about how many bowel movements they had, then they'll say, 3 or 4 a day. So that's the type of patient that you really do not want to use their right colon. Because it's a high risk for being hyperactive. And then you're in a situation where you have to essentially go through a modified overactive bladder algorithm, but of course it's slightly different because this is not a native bladder. So you can, eliminate or decrease the likelihood of that happening by questioning them carefully about their bowel habits, during the preoperative process. If it's orthotopic, of course, if they're already incontinent, you don't want to give them necessarily a neobladder. I always say the only thing worse than having urinary incontinence is also having incontinence with mucus as well. So, of course, this is not going to improve. So if they have significant incontinence, then it's only going to be worse. In the male patient, as a kind of exception, though, you also have the option of them saying, okay, well, can you put a sphincter in me afterwards? And I'll just accept that that's going to be the likely outcome. When we have pelvic radiation listed here, this is really also more so applies to other types of primaries, not bladder, although we do have maybe someone who's failed, trimodal therapy. But for example, colorectal or cervical cancer, for example. So we've, over the past 20 years been, looking as we've, been more concerned about, quantifying people's quality of life. Initially, we used instruments that really weren't specified for this type of surgery. And the original instruments really couldn't help us in terms of assessing how people were accommodating or adjusting to their stoma or their body image, all things that would be altered, that would be different over and above a regular quality of life. And our colorectal colleagues, I think we maybe borrowed some of their questioning because they have, more of a history in terms of evaluating patients that have a stoma. But we now have instruments that are focused on bladder cancer and on the specific issues related to this. And looking at the data, this is a list of series over the past 15 years, and it's kind of a little bit busy, but the studies have been really somewhat contradictory to some degree. There's no one result in terms of saying the neobladder or the conduit is better. There are some studies, and if you look at it carefully, it does appear that you have certain outcomes that are associated with using a particular instrument. For example, when the EORTC QLQ instrument is used, there are several reports reflecting better physical function, higher quality of life in the neobladder patients. However, in some of the bladder cancer index reports, there's lower urinary function in the neobladder patients, and probably this may be related to the more questioning as it relates to continence. And so that really then feeds into what is likely a patient problem related to nocturnal enuresis. So again, going back to just orthotopic diversion, continence in general, again, a list of pouches, then you can see that in some situations that the nocturnal incontinence usually is a bit lower and can be really down to even 60 to 70% in the orthotopic neobladder patients. So in general, if we're looking at post-diversion incontinence, orthotopic and continent catheterizable diversion have a specific mechanism in that orthotopic, of course, it would be sphincteric, whereas if you have a catheterizable channel, that may be an incontinent valve mechanism. But they both can have pouch-related incontinence, so that needs to be evaluated just like you would evaluate overactive bladder. The managing of sphincteric incontinence can be complicated by the fact that the patient is voiding more so by some relaxation and a little bit of valsalva, so you don't want to do something that's going to then obstruct them. So it can make things a little bit more difficult, especially in the female patient. So when you're evaluating these patients, you do the same thing as you would, for a normal bladder in terms of you're looking at capacity compliance. However, you do have to look at contractions that are innate to the type of bowel segment that you have. There are expected kind of pouch parameters in general in terms of capacity. And really, if you look at, this is more of an average capacity, but in the Indiana pouch patient, for example, depending on what their catheterization frequency is, these can go really into the 1,000 range as well. Compliance should be high, and these are low-level contractions that you expect to see. Of course, small bowel will be lower amplitude than large bowel. Transurethral injection, that's been tried in the past for sphincteric injection. I've tried it. You see how eliminated the collagen because it's no longer available. And I have, frankly, not tried Bulkamid or a macroplastic type agent in these type of outlets. But you do, again, have to be careful about outlet obstruction. This is another subsequent paper from Marcus Queck. Again, collagen is gone, but the success rate is low. So this is not generally, especially if the patient has severe incontinence, this is unlikely to help them. The pubovaginal sling type approach, especially in the female patient, can be somewhat complex and usually associated with a complication, if not an expected hypercontinence. ACT has been utilized in these patients. This is like a single report, and maybe Brian, since he uses ACT, may be able to chime in later, but there was no follow-up report, and I would be concerned about trying this. So what we end up really managing is nocturnal enuresis, and there are some behavioral approaches to treating this, just like any other patient that complains of nocturia, for example, or nocturnal enuresis. You can also use imipramine as you would in a pediatric patient. But I find that these patients often, especially the male patients I'll specify on, have very severe incontinence. My go-to is an artificial urinary sphincter with daytime deactivation and nighttime activation. And in this patient, you can see here's his PRB. This is one I did probably maybe 12 years ago. So it was before we were doing submuscular placement. So this is an intra-abdominal placement because as you know, there's no retropubic space. In this case, it did not have a problem, but there is a risk of bowel obstruction and having a bowel adheres to the capsule. I've heard people say that a capsule does not form around an intra-abdominal pressure regulating balloon, and having gone back and operating on someone, it does, and then you can have the bowel adhere to this and then end up with a bowel obstruction. But in any case, in this patient, they've had this device for 12 years. Briefly on decision regret, this is something that's also been looked at in prostate cancer patients. And what they found in this fairly recent study is that there was no decision regret in terms of when you look at conduit versus neobladder patients, but what it was in relation to the amount of information they received. So we sought to look at how we could improve our patients' perioperative experience. And this is a very complex, it's more straightforward for urologists, but very complex for the patients in terms of just a complete change, a lot of information, and we have to deal with the fact that we may have biases based on what we think would be appropriate for them. There's patient health literacy, the information that they are getting from multiple sources. So we wanted to see how we could improve our perioperative process. So we looked at patients who were 6 to 12 months post-radical cystectomy, semi-structured interviews by 2 urologists, open-ended questions with unscripted follow-up questions. Here are an example of several of the open-ended questions. What would you want to know? What would you tell other people? What particular time during this process would you like this information? Common themes were identified. We used our health services research department to really help us with this analysis. The interview was reviewed, and the presence or absence of themes and emotions were noted. So we interviewed 13 patients. They were roughly evenly divided between diversion types. None of ours expressed regret, and those with the continent diversions, these are patients that somewhat self-select, and they have a tendency to be really motivated and look for other sources, and BCAN was the most common. What patients did say who had appliances or catheters was that they really had a difficult time adjusting to this. Did they feel well counseled? 77% said they felt that they had adequate information. But despite the fact that they did get counseling preoperatively about complications, there was some surprise. I mean, we tell patients, oh, you may have an ileus. What does that really mean? You may have a fluid collection that means draining, but then when it happens, it's still somewhat surprising to them. None of them felt a change in their body image, and the majority didn't feel like it impacted their daily function. And the continent diversion patients were worried long-term as they aged whether they would then experience incontinence. Most of them had a desire for a type of buddy system. This would have been the #1 area for improvement, and they said that they would be willing to talk to other patients as well. And they realized that, physicians are experts in doing the surgery, but maybe not experts in how to deal with it afterwards. Here are some of the comments regarding, their direct quotes from them in terms of the care and maintenance being consuming. They would tell somebody that it's going to get better, that they realized that they needed to talk to other people and they needed to talk to their families. So our study highlighted the need to focus on post-surgical maintenance care, counseling, so partnering with woundostomy in terms of the equipment that's needed, and that peer-to-peer support is really important. And so ultimately, diversion selection has to take into account factors that are patient-specific and that they have unique complications. And so we need to be sure that that particular patient can handle the worst-case scenario and that we have sufficient support in the post-operative period, regardless of what the diversion type is. Thanks.